Hello, good evening, and welcome to another EA Just Ask, your monthly live appointment with a leading expert in implant dentistry. My name is Gerrit Heijkoop, and I'm the host of this EAO channel. And tonight, in this live video session, we are going to try to answer all your questions about a minimally invasive bone regeneration technique in compromised sites. And we're playing high stakes here. We're talking about the aesthetic zone. To do so, I'm very proud to be joined tonight live from Boston in the United States by Dr. Marc Nevins. Marc, good evening. Good
Good evening.
afternoon to you. Yeah.
Afternoon here. Welcome.
Yeah. Welcome to this EA YouTube community. Now, for those of our viewers who don't know you, you are a assistant clinical professor of oral medicine, infection, and immunity at the Harvard Dental School of Medicine. You are in a private practice in Boston where you've performed the technique that we talked about tonight for over 3,000 cases already. And you are a co-editor of the International Journal of Periodontics and Restorative Dentistry. So a very true expert indeed. And I've just asked our live viewers in the chat that if they're joining us live, please let us know where they are joining from. And if I look at chat, we have a very international crowd already. We have Mitchell Pierce from New Orleans, who was here early. We have Per Otterstad already submitting a question. Victor from Moldova. Declan from Dublin in Ireland. Michael Poyer, one of our previous experts, is with us from Austria. Mustafa Hussain, live from Iraq. Isabella, live from Italy, I suspect Isabella, or maybe London. Alberto is joining us from Alicante in Spain, Stefano from Milan, Christopher from Sweden, Tali Shakachi from Israel, our expert from our last EO just asked. So a truly international crowd together. Now, Marc, I propose before we start to take as many of their questions as they have, to kind of start to introduce this topic by dissecting this title a little bit, because it has basically three components. I already said we focus on the aesthetic zone, so high stakes, less than millimeters matters to our work. But then the other two parts, we're talking about the minimally invasive bone regeneration technique, a very specific one, and we talk about specific compromised sites. Let's start with that. What does that mean to you? What is a compromised site in your
Well,
practice?
I think there are two sides to what we'll talk about with this today. I think a lot of times we're dealing with a fairly pristine area, like if you broke off your front tooth today and it hasn't had any disease around it and you broke it off at the gum line and there's not yet gum recession or bone loss or soft tissue loss, then we're going to manage your case. We want to make sure we are able to do that in a way which doesn't cause iatrogenic damage by the work that we do. And so even a case that's not yet compromised, we want to make sure we keep control on that. Secondly, we have sites where we either have soft tissue loss or bone loss or a combination thereof. I think a lot of times we see sites where we have fairly good volume and soft tissue contour to begin with, but we've had extensive bone loss due to a tooth fracture. And that's why we're seeing the patient to make a transition to an implant. And we have a lot of challenges trying to maintain the aesthetic foundation of the soft tissue and sort of the backdrop for the aesthetic crown that's going to be done, and finding the best way to do that, preserving the volume, preserving the contour, preserving what's going to be the most really important aspect of the aesthetics. You can do beautiful ceramics, but if you're missing a millimeter or two of soft tissue and you have a contour defect or papilla loss that wasn't there before, then that makes it really hard to get the aesthetic result that you're trying to achieve for the implant crown.
Exactly. And I believe you have, just to kick us off, you have some cases ready for us to kind of show what we're talking
We
about
can
tonight,
sort
or
of
what you are talking about.
I think, laying the groundwork on, this type of technique, I'll just throw up, let's start with, a patient who their upper left central incisor, we have normal soft tissue contour, but we can see the tooth has become malpositioned. It's sort of erupted and flared a little bit. And she actually had fractured this tooth and had been cautioned by her dentist not to get started on an anterior implant. These can be difficult. The aesthetics can be difficult. And I had seen her many, many years before. And at this point, she came for a second opinion because she just knew something wasn't right. She was having pain and discomfort. And by the time she came to me, we see there's 100% loss of the buccal bone here. And what has to be realized in a case like this is that when this tooth is removed, the soft tissue is going to collapse. And whether it's just on the facial or it's the papilla. And we have a challenge here of how to maintain the bone, how to regrow the bone, but also maintain the soft tissue contours and to get the foundation that we need for implants. So, I mean, this is a pretty sort of the far side of the spectrum, but the question is, are there techniques today where we don't have to do large block or large GBR style procedures to be able to stimulate the regeneration of this bone? And we hopefully we'll have time. We'll come back to this specific case later on. There's a couple of publications here, a CE book, and then this is published in the Journal of Aesthetic and Restorative Dentistry. So some references, if people are interested, we can put these up in the chat afterwards. But here's a case where vertical fracture of the root. The patient's been sort of walking around with this as she was finishing graduate school, and sort of looks at me with a straight face and says, "Do I really need to have this tooth removed?" And she's already been talking to her dentist and had some other consultations. And the challenge here as a clinician is, if I take out this tooth and we lose the pink papilla in between the teeth, the patient's going to blame me because, well, they were there before the procedure. All right, you're responsible now. But if we look at the radiograph, we can see that there's just a very thin plate of bone on the distal of the central incisor and barely even visible on the mesial of the canine that's supporting those papilla. So we have to be somewhat strategic in what it's going to mean to handle this surgically. And, you know, if we're doing a conventional approach with bone grafting, we have to consider, if we lift those papilla away from their position surgically, what are the risks of them not maintaining their volume when we put them back surgically? And the other question is, are there surgical approaches both with flaps and without flaps to try to manage this otherwise? And one of the big benefits of growth factor enhanced or induced healing is that it pulls cells also a periosteal healing effect. So this tooth has about an 8 millimeter buccal probing depth of pocket. So there's really no bone on the buccal surface. And a lot of conventional approaches are thinking about the mechanical barrier. So setting up a barrier to the soft tissue cells so the bone can heal, and figuring out, well, how am I going to protect that with the barrier membrane? And with growth factor enhanced healing, we can pull off this periosteal wound healing and draw cells and blood vessels from there to enhance the healing. And so we don't necessarily have to wall that off with the membrane. And it allows us to take a very minimally invasive approach. And if we look at how this case was handled, it was done with a flapless surgery. I extracted the tooth and then used magnification to completely debride and degranulate. And that's a pretty thorough process. It might take 15, 20 minutes to degranulate an area like this, where there's 100% loss of the buccal bone and maybe 4 millimeters loss of the palatal bone. And I'll use 10 cc syringes, irrigation into the socket to sort of rinse out and separate any fibers of granulation tissue. And a lot of times on these, you'll clean and think it's completely clean. You'll rinse it again, dry it, use magnification and a mirror to look inside, and you'll see, oh, there's still fibers there. You start cleaning again and sort of going repetitively through this process of using a 10 cc syringe with sterile water or sterile saline, spoon curettes, Gracie curettes. Sometimes I'll use piezo instrumentation as well until it's completely debrided and degranulated. And then all I've done is condensed a pre-soaked allograft bone graft that was soaked in recombinant human platelet-derived growth factor, BV. And I packed that all the way up to the soft tissue level, covered that with a small piece of collagen membrane just in the opening of the socket. We haven't put that at all under the tissue, just at that opening, and stabilized that with some medical grade cyanoacrylate. And that's going to heal in a way that we can see a confirming radiograph to see all the root fragments were out. And here it is 4 months later in a periapical radiograph. It looks like it's filling in well. And part of my strategy when I talk to a patient about this type of case is that my goal is to regenerate the vertical support for the soft tissue and to stabilize an area that's not very stable right now. If we need to come back and do a lateral bone augmentation, well, that's something we can do pretty predictably without losing the papilla. And we're going to diagnose the implant potential with 3D tomography once it's healed. And in this case, we can see there's plenty of bone to support the implant. So we're now going to go and move ahead with our implant placement combined with some soft tissue grafting. And here we can see the pre-op on the right, and we can see the smile and the clinical view. And we can look at the view after 2 years post-op. It's maintaining very well the way that we would expect it to. So I think, you know, let me just turn this share off for a minute. And I think this sort of lines up with a definition of, you know, what do we mean by compromised sites? Well, we can look at the first case where you have 100% bone loss, and we might come across someone who, well, I don't do those cases. Well, then that brings us back to what about the case where you have healthy bone and soft tissue, and you have to figure out the choices of how do I manage that the correct way. And that brings in a lot of challenges and choices. There's choices of when to do an immediate implant and when not to, and when we could do an immediate implant and just maintain our soft tissue contours versus combining any bone preservation grafting with soft tissue grafting. And so, you know, that part of the topic has a lot of bandwidth that can take us in a lot of directions. And I think we'll have time to touch on that a little bit, and maybe we can show a little video of the case, and then hopefully we can get into a little bit of the biology aspect
as well. Yeah. There's a lot to talk about, but to understand you correctly, if I listen well, you say my key drive. Well, you have explained two very clear compromised sites, and you say my key driver not to go for a conventional bone regeneration approach is the maintenance of the vertical levels of the soft tissue. Is that correct? That's why you choose a different approach.
I think any time that we are working in the aesthetic zone, we all understand that if we make an incision in a flap, we're going to change things. And if we can be strategic and get the bone to regenerate without changing the contours of the soft tissue, that's favorable. At the same time, I always turn to Uli Grunder's research, where he's shown us how important it is to enhance the thickness of the soft tissue around aesthetic zone implants so that we don't get any recession. And so in order to do a connective tissue graft to thicken that biotype, well, we're going to have to do some type of incision, whether it's a tunneling technique or a flap or submarginal, you know, at some point. But there's differences in doing that once the area is healed versus doing that at the time of extraction. Myself, if I make a flap at the time of extraction, I'm creating mobility to that tissue. And I'm going to want to advance that flap to get closure to seal that off. On the other hand, if I'm doing a truly flapless approach, then I am able to keep things very stable, and we don't get that micro movement. And that can be very helpful as far as having control in a flapless environment. A lot of people think that if they lift the gum a little and put it back where it was, that's flapless. Flapless means keeping the flaps tissue where it is with their periosteal attachment in place. And that has to do with micro movement and wound stability.
Exactly. Now, that means I think you're making us really curious to the specific technique that you use. I already see Antoine El Asmar writing. So what is the procedure? Well, he's referring to a specific case, but I think we are all very curious so what you do and how you do it. But before that, Marc, maybe it's good to underline that you are in Boston, that is the United States. We are talking on the channel of the EAO, the European Association for Osseointegration. The technique you present today is not available worldwide, right? What is the status?
And I think also, so there's a product, Gem 21S, that's been for sale in the United States since December 2005. And that product combines a synthetic bone graft, a beta TCP, with a syringe with 0.5 mLs of 0.3 mg per milligram of PDGF. And that PDGF growth factor, biotech engineered through recombinant technology, so it's a synthetically engineered pure human protein, is approved for periodontal treatment for growing bone and gum around teeth. So everything we're really talking about, except for, we'll show some of the research slides that were done in the periodontal studies. The rest of what we're talking about today in the extraction sockets and implant preparation is all what we consider in the United States off-label use from the actual indication. And we've actually, in my office, we've done somewhere between 4,000 and 5,000 treatments with this product since December 2005. And probably about 85% of those are for off-label use for implant site preparation. So we have a lot of experience with this. It's not EU approved at this time.
Exactly. Now, with that said, please take us into the sequence, the workflow, the protocol. How does it work?
Yeah, I think, the ability of growth factors to regenerate bone, I want to just share a slide with another example. And if we focus, this is a paper by Craig Mish, who's a fantastic surgeon. But in this case series, what he's showing
At the moment, Mark, we're not seeing your slide or your screen yet.
this.
Yeah, there it is. Yeah,
So
much better.
this is a publication by Craig Mish and Jomi quite some time ago. And Craig has great surgical skills, but what he's showing here is growing bone with the technology of a growth factor. In this case, it's bone morphogenic protein 2, BMP. And if you look in the cross section of the central incisor, it's not that different than the case that I showed the CT scan of as a first example, with a very potentially difficult site to place an implant. And all he did was extract this tooth, take a collagen sponge that was soaked in BMP2, put that in place, and here we can see in the post-CT scan how much bone he was able to regenerate. And there's some differences between BMP2 and PDGF. BMP2 is a morphogen, so it's going to pull mesenchymal cells into the wound and stimulate them to change into osteoblasts. It's a pretty intensive inflammatory reaction to make that happen. On the other hand, PDGF is a mitogen. It's going to draw the periodontal ligament, cementoblasts, and bone-forming cells into the wound. If it's a periodontal wound, if it's an extraction socket, it's going to pull those bone-forming cells in, expand their population, and stimulate growth in new bone. And we can, let me just see here. Maybe we jump ahead a little to the biology, and we'll go back to the clinical cases a little bit, because I think it's a good place to start.
Yeah, go ahead. In the meantime, while you look that up, let me welcome our viewers from all over the world. In the meantime, people have joined us from Antoine from Lebanon, Gerasimos from Amsterdam, the Netherlands, Marianne from Paris, we have Jose from Brazil, we have Mario from Mexico, Tung from Istanbul, we have Gevorg from Moscow. So, Mark, by now we literally have a truly almost global. We're missing
amazing,
a bit the Asia side.
Amazing platform and technology. Thanks for hosting me.
Exactly.
So, if we go back to classic literature here, work done by Dan Boozer and Bob Schenk in the early 90s, they taught us about membrane protected defects and really taught us a lot about guided, really established the concept of guided bone regeneration in the dental field from a clinical application point of view. Even though the science dates back in many years before that, from a clinical application, they really brought us forward to where we understood the biology. And here on the left side, we see what we consider a critical size defect. So if we make this defect, it's going to repair from the edges, but only with minimal bone fill. So if you look at that control picture where my arrow is here at 2 months, we see there's a little bone ingrowth from the sides. We basically still have the complete defect. On the other hand, if we take the membrane protected defect, and these were filled with venous blood to be sure there wasn't dead space there before the flap was closed, we can see that this is almost completely filling in. At 2 months, we see the bone ingrowth. At 4 months, we see about 97% fill or 95% fill. But what you can't see at 4 months, that shows clearly at 2, we see outlined in blue that the bone is ingrowing in from the bone walls. We call this osteoconduction, growing in from one bone wall area. And we need to sort of separate that from the concept of osteoinduction, where the bone is growing evenly throughout the whole defect, which we see with more osteogenic bone healing. And if we look back again to an example of BMP2, on the left side is an extraction socket with complete loss of the buccal plate. A collagen sponge, ACS, absorbable collagen sponge, was placed at the time of extraction. In 4 months post-op, we see almost no bone growth within what would have been the socket, where there was no bone wall protection and there was no bone graft or growth factor. It was just the absorbable sponge with saline. On the second example, we have a similar type of defect. We have about 70% loss of the buccal plate and just this thin bone wall remaining. the ACS was placed again, but this time instead of soaking it in saline, it was soaked in recombinant human bone morphogenic protein 2, similar to the example that Craig Mish's case. And we can see at 4 months almost complete reconstitution of the bone. So without any bone graft material per se, it's really for those that say, well, I don't know if a growth factor works. Well, I think that this clinical trial example that's so well documented really should open the eyes to say, well, I understand if this was just a collagen sponge, we would have almost no bone there. And so it sort of should open the attention a little bit to the concepts of what can be done with growth factors. As far as our pathway to clinical work with PDGF, when I was a resident,
yeah, that is the technique we're talking about tonight, and Marc, platelet-derived growth factor.
All the cases I'm going to show tonight are combinations of bone graft material as a carrier vehicle scaffold with platelet-derived growth factor BB, recombinantly engineered. So if we shift back to that, you can go back. There was an early study in the 90s published by Howard Howell and co-workers combining insulin-like growth factor with PDGF and periodontal defects. And in the furcation defects, delivering that just in a gel, not even in a bone material, they showed about 3 millimeters, which is pretty significant for anyone familiar with periodontal research, 3 millimeters of bone gain in furcation defects in the growth factor treated sites. And in the control sites, it was about 0.1 millimeters. So the ability of the growth factor to induce periodontal healing was very well documented in that study using just a gel as a delivery agent. As we get into implant procedures, we're usually going to use this on a bone graft material as a scaffold to help support the volume of tissue for the new growth. And here we have an example of a periodontal defect where we have advanced attachment loss. Before cleaning these teeth, we took a burr and made a whole thin indentation, or calculus notch, we call it, a groove in the tooth at the level of the calculus. So when we look at the histology, we can say, well, that was disease. It had plaque and calculus on the tooth previously. And we can say it's not just where we've opened the gum and put it back and it's reattached, but it was actually diseased area. And if we go to the middle slide, right where my pointer is, we can see that notch on the tooth. The apex of the tooth is at the top of the screen. You can see it bulging where the crown of the tooth, you can see some enamel here on both sides of the tooth. And if we take the distal area of the notch and magnify it, well, we can see the notch now has a thin layer of new cementum that's regenerated on the root surface. We see these vessels in a vascular periodontal ligament that's well oriented to support the function of the tooth, and we see it attached to new alveolar bone. So we've met our criteria for periodontal regeneration, which would be new bone, new cementum, and an intervening periodontal ligament. And when we look at that panoramic view on the middle screen, we can see there's a significant amount of regeneration. We can see these lighter gray bone graft particulate that we use to deliver the growth factor, and we see the deeper magenta color is the new bone. Mm-hmm. We can see another example from this particular study, and here we have a furcation defect with deep bone loss surrounding it, and we're able to look at this histologically. These histologic specimens were evaluated after 9 months of healing, and we can see the end bone coming all the way up to the fornix of the furcation, where we see the NC, the new cementum, and we see the intervening periodontal ligament in between. If we go to the right side where the notch is, sorry, let's go back again, click that by accident. We can see, again, the new cementum filling the notch, the periodontal ligament, and we have an arrow on the blood vessel, and we see the new bone. So we're able to stimulate periodontal regeneration with this. This is a series from the pivotal trial that was used for FDA approval of the product. And in this study, teeth had to have at least a 7 millimeter pocket. So we had sites that had advanced periodontal bone loss. And these sites were treated surgically, either with a carrier vehicle alone, just a synthetic bone material, or with 1 of 2 doses of the growth factor. And the PDGF sort of turns on a switch and optimizes the healing for regeneration. And what's interesting is in the pivotal trial, the dose that's available commercially is 0.3 mg per ml, whereas there was a higher dose that was tested, and actually the lower dose turned out to be the most optimal healing with the most bone and clinical attachment gain. And it's sort of interesting. I really think about it as sort of turning that switch and setting up an environment and changing it from a reparative environment to a regenerative environment where you have this big inductive effect in healing. And if you compare the 8-year post-op radiograph here, we all would understand that this tooth should be in service for this patient's lifetime. It'd be nice if she also added some implants posteriorly to replace those teeth. Whereas if you look at the first radiograph, I think your question would be what kind of implant are you going to place there? But we were able to regenerate the periodontium. You can see in the middle 1-year post-op reentry that there's about 4.5, 5 millimeters of periodontal bone healing on clinical measurement in this case example.
Exactly. So this is demonstrating the biology between this behind this growth factor, the scientific evidence, and all the way up to the, as you mentioned, pivotal study for the approval in the United States. With that said, again, I think our viewers are on your lips, as we say in Europe, to learn how you apply it. How do you use this growth factor in this minimally invasive bone regeneration cases?
Well, I think then, let's go back and let's share the screen here again and look at another case example. And I think a lot of people, if they're thinking in the aesthetic zone, had a lateral incisor with 75% bone loss support on the papilla, that they'd be saying, well, I'd like to do an implant, but I don't know if I'm going to be able to get the aesthetic result I want to achieve. And what the same technique I'm going to show in a second was used here, where flapless socket grafting was provided, just like we saw in the last case. And then at the time of implant placement, a small connective tissue graft to augment the biotype was provided. And we took what could be a fairly complicated case and made it very straightforward and very predictable with the approach. And we'll look at a video example. Let me go here. You can see that on the screen.
Yes, we see it very well. Very
Great.
Curious.
So I'm going to start the video here. I'll pause it when we get to his smile line in a second. We have a central incisor that's fractured at the gum line, and we can see he has a high smile. There's a provisional crown that was made, and it was determined that we would be better with an implant than making an effort to restore this tooth. And here in the intraoral view in the cone beam CT scan, this is the time that may be most important, more than what we do mechanically, is what decisions we make. Mm-hmm. And in this case, I spent a lot of time with the patient going back and forth into the risks and benefits of an immediate implant, or an immediate implant with immediate load, or immediate implant, immediate load, and connective tissue graft, noting how thin his tissues were. And in the end, the critical decisions for me were how important those small 0.5 millimeter levels of tissue were going to be to his aesthetic success, noting on the cone beam scan where the bone level is, that although the tissue is here, the bone level might be about 3 millimeters higher. So the tissue is going to want to collapse a little bit. And I want to make sure I have the most control. And he was willing to take the extra time to do this in a staged fashion. And so that was what we selected here, using the techniques that we're talking about today. I think this is rolling and just rolling.
Yeah, it's rolling. Yeah, it's your time to talk over it. And we're really getting curious now. So what happened next? There we go.
I like to use piezo surgical instrumentation for extractions, and I typically use a scalar tip, this PS2 tip down the periodontal ligament space. I find that this is most invasive because it's not really cutting the same way that a flat tip would, where you can cut into the bone or into the root. And I just use it like how a lot of people would like to use a periotome, but I just sort of take my time using that down into the periodontal ligament space with very light and intermittent pressure. And at the beginning, sometimes the bone's a little cortical. You may find, oh, it's not going to extend anywhere, but just being patient. And even in maxillary canines, I'd say about 80% of the time, I can extract those teeth without removing any buccal plate, and none of the buccal plate was damaged here. Once it was removed, we degranulated the area. While he was getting numb, I soaked a gram of freeze-dried bone allograft, which is most typical for us to use in the United States. I think in Europe, the use of xenografts is a little bit more common. You could do the same thing soaking in the xenograft. And now I'm gonna condense that allograft into the socket incrementally. And the allograft is going to, same you can do with the xenograft, sort of mechanically condense on itself. And by doing this incrementally, it's going to give us a better chance of sort of having this very well stabilized. And you'll notice that I'm over condensing. So I'm actually building this up all the way up to the soft tissue level and just sort of working slowly, condensing this in place. But that mechanical stability, if in a single tooth socket like this, and we can maintain 100% of the graft in place, even after a couple, or 80, 95% after a couple weeks of healing, then we're going to be able to maintain our contour best. We're going to talk about in a few minutes what happens if you don't maintain all that graft in place, because that brings us back again to the growth factor enhanced healing aspects. But basically, I'm going to continue to condense this, and once I have it condensed the way I would like it, I'm going to take a small piece of a collagen membrane, and I'm going to fit that just over the surface of the socket. So this is much different than a lot of people have seen, sort of like Dennis Tarnow's ice cream cone technique, he calls it, where he placed the membrane down into the socket. Here, we're only going to have it acting as a mechanical barrier over the surface.
And then its function is just to keep everything in place?
Just purely mechanical. Exactly. And I'll use a little sterile water or saline to, if I need to sort of wet that down into place. We want it to sit pretty tight against the bone material. And then the choice here is, am I going to use sutures or am I going to use a medical adhesive? And I prefer a medical adhesive for multiple reasons. If I have sutures here, those sutures are going to get loose after 24 to 48 hours. The looseness or mobility that causes is going to cause micro movement, which is going to cause attraction of bacteria to the movement. And that's going to cause me to lose 1 millimeter or 2 of graft particles, most likely. So by not having sutures, once this becomes unstable, it's going to come off and leave the site. And that's why my recommendation is to do this with a medical grade cyanoacrylate. I use periacryl, sold by Bootlich is the company, and I've used that for at least 15 years for this type of work. We'll see there's a case example, maybe the first case I did using the growth factor in 2006 for anterior tooth, where we used a suture, and we'll see that later on. Typically in the early healing, I prefer an Essex appliance like this so that there's no pressure on the wound. And let me just stop that video. Pause that. And as opposed to a Pontic or a bonded Pontic, if we're going to use a bonded Pontic, then typically I would wait till the early phase of healing is complete, anywhere from 2 to 3 weeks, and then have a bonded Pontic, a Maryland prosthesis, or if it was going to be a fixed partial denture Pontic, have that put in at that time. I don't want debris caught between the Pontic and the healing site. Just like the sutures would cause a problem, that would cause a problem and tend to lose height. Or if a lot of debris causes a lot of bacteria, rather than losing 1 millimeter like the suture would, I might lose 3 or 4 millimeters, which would now create a clinical problem that we have to solve later on. And when most patients understand why we want to use that type of appliance, they tend to do better with it than you would expect. Even from 3 feet away, you wouldn't have a big aesthetic concern with it. Obviously, there are functional aspects that have to adapt with speech and eating, but most people can do pretty well with that. I think an important side note to touch on is, let's go to a molar area, for example. We can use the same technique where we have 100% loss in the buccal plate, which typically would become a pretty big surgery if we're going to do a GBR procedure at the time of extraction, advancing the flap for closure, and so forth. So what happens because the bigger socket, if the graft gets washed out, if it wasn't, you condensed it the best you could, but it didn't stay in place. What I tend to see is for these sites, even whether it's 25% particle loss or 60% particle loss, if you looked at 3 to 4 months later, a site that all the grafts stayed in place versus a site that a lot of the particles came out of in the early healing, by 3 to 4 months, they mostly look all the same. And I think, you know, the next sort of question is, well, how does that happen? And I think
Yeah, why is that, Mark? Why doesn't it really matter?
Let's jump back into the biology a little bit. And if we go back,
if you may, before you take us into that, because in the end, let's pay dues to the title of this session, which is also EAO's Just Ask. I quickly want to tick off the first few questions that came in early, also to prove to our audience that we are live and we are taking questions, and then we dive deeper into that biology there. So hold that thought. I'll take you back there in a second. Because Mark, one question came in already way before we started from Mitchell Pierce, joining us from New Orleans, and he says, what role does soft tissue augmentation play with this, or he says with minimally invasive bone regeneration? Obviously, you didn't demonstrate the technique at that point, but what's the role of soft tissue augmentation here? Well, or is there no need?
For me, in the aesthetic zone, I'd say 95% of implants are going to have a soft tissue graft.
Exactly.
So almost all the time, we're going to be augmenting the biotype. I think the big question that we get into is timing. You know, when is that being done? For me, most of the time it's being done at the same time as the implant placement. And most of the time with these techniques, I'm regenerating bone first, or there are times I'm doing immediate implant and doing it at the same time. And there are times I'll do an immediate implant and do a soft tissue graft at the same time, and sometimes combining that even with immediate load. There are other times where I'll do an immediate implant and come back secondarily to do a soft tissue graft, and it just will depend on that. But most cases are going to have a soft tissue graft.
Exactly. And you say how and when and where really depends on the case.
Yeah,
I have all flavors of it.
Yeah.
Yeah. And then the other question, and it's slightly maybe off topic, came in early from Per Otterstad. He says, in case of a missing buccal bone wall, like we saw in your first case already also, of the socket, will the use of PRF promote bone growth from the remaining 3 walls of the extraction socket? And I know tonight we're not talking about PRF, but maybe it's good to really explain the difference there.
Yeah, I mean, here's your missing buccal bone wall if we look at the slide. And I think the difference is that the PRF or LPRF or advanced PRF all works from a synergistic function of a series of growth factors that are found in the platelet gel. And let's assume we're talking about the more advanced techniques. Even with those advanced techniques, the recombinant concentration of PDGF that we're using in the biologic that we're talking about tonight is probably about 1,000 times the dosage of what you're going to get in PRF. There are some studies that say up to 10,000 times, but I think 1,000 is probably a fair number. And I think there are times where you could have a buccal plate bone defect, say in a bicuspid region like this, use a flapless technique, treat this with PRF. I've seen there has been a lot of research done on this, but I've seen some case study examples with very nice bone healing. I think when you add a bone graft scaffold with the PRF, given the potency of the PRF being at a relatively low level biologically for bone healing, that you probably are starting to limit the bone effects of it that are going to be somewhat adjunctive. Okay, PRF is going to be very adjunctive to soft tissue healing, but we have very little evidence in the literature as far as its potency for bone healing in a way that can be a paradigm shift of how we would approach the surgical treatment, similar to what I'm showing tonight. And so for me, having some experience using platelet gels, mostly about 20 years ago, I really didn't find the potency of the growth factor to be able to change my approach to treatment. And that's where, with a recombinant growth factor, I found that I could change the approach. And if we look at this from a biologic aspect and look at how it works, we can look at this case series where this was a flap technique case series with primary closure. in the bone scaffold was a xenogenic scaffold combined with 10% collagen. So it was 90% mineral particulate with 10% collagen. It's a BioOS collagen product is what this is. And what's nice with that is it sort of has a spongy nature. So we're able to place it in this non-contained buccal wall socket defect, add another layer of the graft material over the surface, and the graft would stay in place and not have to have another factor contributing to the study, such as a membrane. And we wanted to focus as much as possible on understanding what the effects of this combination was with this single scaffold, no membrane, and the growth factor. The flaps were closed for primary closure. And in this first study published in 2009, if we re-enter this after 4 months, we see really fairly mature bone in this site, even at 4 months of healing. We see a couple white specks clinically up on the buccal surface, representative of the bone replacement graft. But if we take a bone core and we look at a microscopic CT scan, we can see all the intensive new bone trabeculation formed around the graft particulate. We see the graft particulate in white, the new bone in red. We get up to native bone apical to the socket at the top of the core. And if we look at the bone histologically, the bovine graft particulate is the BO, the NB is the new bone. And we can see that almost the whole surface of the bovine graft particle is completely covered by new bone, which is thick trabecula that are interconnected with the adjacent bone trabecula. So sometimes in like a socket graft at 4 months, you would see the islands of bone graft material, and then you'd sort of see waving in between some new bone formation, and it'd be touching the graft in spots. But at 4 months without a growth factor, I don't think it's very common to see almost every particle of the graft completely encirculated by new bone, and those trabecula wide and interconnecting with some lamellar bone, if we even showing up at that phase. And additionally, what was interesting is we saw these multinucleated giant cells with reversal lines on the surface of the bovine graft particle, which seems to be representative of resorption and replacement, although it's not confirmed just with the histologic example. And we can go and look at some of the work done from Will Gianobili's lab. And this manuscript by Sermont tried to look at surrogate markers for bone turnover. So if I tell you that the growth factor was only in that wound for 24 hours, if you measure it 2 days later, it's not there. You're not going to be able to barely pick any of it up if you're measuring for it.
So that's back to the analogy of really turning the switch that you mentioned earlier. So exactly.
If you want to think of a room full of dominoes, it takes 10 weeks for all the dominoes to fall. The biologic terminology is a cascade effect. That cascade effect carries on, and we don't know, we don't have, it's hard to capture this type of research. But in the pivotal periodontal trial, there was samples of the tissue fluid around the teeth taken at different healing times. And from those samples, different things can be measured. And one of the things that was measured was ICTP, which is interstitial collagen telepeptide. It's a bone-specific collagen product. And people might be familiar with CTX, which is another bone-specific collagen product that we use as a marker when we're trying to evaluate patients on osteoporosis medicines to see what's their bone turnover. And in this case, it was the ICTP. And remember, we had 2 treatment groups, the blue and the green, and we had a control group in red. And you can see at 6 weeks, there's quite a difference in the bone metabolism of the surrogate marker here in red of ICTP at the native level versus what we have in the 2 treatment groups. And at 12 weeks, we still see some separation. So for myself, I like to think, I can expect a biologic effect in that wound for at least 8 to 10 weeks. And when I first started using this, I had a case with a PTFE membrane surgery where the membrane got exposed. I removed the membrane early, but I would have expected the healing in that case to go downhill. And what I saw over the next week was it almost rebound and recover once I got the membrane out of the way. And that was the first case, that was at 3 to 4 weeks, where I said, you know what? The healing response here seems different than what I would see with typical non-growth factor surgeries. And it was a couple of years later when we had access to this beautiful research, sort of explaining it to us, why, how does it, can we really prove that that bone healing metabolism is elevated for an extended period of time? And I think this study is pretty critical for that.
Yeah. And is this then also the main reason where I interrupted you with some of our viewers' questions where you said it doesn't really matter if we lose a bit of the particles because the effect is in the end still
Well,
the
that's
same?
exactly, bring us right back to that. Thank you. I meant to connect those two, but that's exactly it. So even if we've lost the particles, we have a growth factor mediated healing happening in that wound, which is going to happen through a different pathway than we're used to, not just the graft particles being there. And we'll actually, even with that secondary healing, see bone fill up into that defect over the next several weeks during the healing. And then when we come back and look at it a few months later, you really can't tell which sites had the poor early healing versus which sites the graft material stayed in place. Fortunately, in a single tooth site in the aesthetic area, more narrow socket, most of the time you're able to maintain that graft in place. So you even have the most optimal contours.
If I may, before you go into the next case, there's a question slightly related to that by Hussam Hassan, who says, what is your opinion on sealing the socket with a FGG, a free gingival graft, instead of a membrane? Is that any, well,
So
what is your
I
opinion
think,
is the question.
When you look at the socket seal technique, and now the author is jumping my brain, a friend of mine from Israel, and what strikes me about it is he published an initial paper back in the late 90s, and you go back to like a 15-year paper, and I think there might have been 212 cases in the 15-year paper. And I scratched my head and I say, well, how much utility is this? Is this something I want to do on an everyday basis? My own experiences was sometimes those grafts took, and sometimes they didn't take. And the time that I would use that myself the most is under a pontic when I don't want to use a membrane with glue, but I've committed to doing a minimally invasive technique, even though, as I said before, I try not to do it under a pontic. That would be the time that I tend to use it the most. But in most cases, I tend to use what I showed in the video of a collagen membrane and a medical adhesive.
Exactly. Well, Tali Shakarchi is joining us live from Israel. Kobe Landsberg is what she's writing in the chat as well. Yeah,
Kobe Landsberg,
yeah.
Great periodontist from Tel Aviv, and he really beautiful work introducing this to us. But it was in his more longitudinal study. When I look at the numbers, and you look at this, if I've done 4,500 cases with PDGF, I've probably done 2,500 or 3,000 cases of extraction sockets treated the way that I've shown. So it has a lot of everyday utility.
Exactly. You're about to take us into a case, Marc.
Yeah, I was going to go on and look at just a canine that had a vertical split. So it was severe bone loss. The socket was at least twice as wide as this very large canine. And you come back at 5 months and you can see this good fill in the periapical radiograph. And here, if we look at the histology, again, we see very robust bone healing. The graft particle is gray, the new bone is purple. But if we focus on where we say FDBA here, we can start to see that, well, I don't understand. Now where we're supposed to have the graft particle, we're seeing this purple area taking up the space within the graft. And I would suggest that the geometry of the graft particles already getting resorption replacement with new bone at that time point. And some of the histologic samples looked a little strange to us because there was so much activity within the graft particles when we first started looking at these early socket samples that we took many, many years ago. And when we look at how robust the bone healing is, you have to say, well, how does that happen? I understand that it draws the cells to this area, but there's actually a dual pathway, a direct and an indirect pathway of inducing the healing. And I don't think I have the slide here. If it's in here in a few minutes, we'll see it in a few minutes. If not, it's another study out of Will Gianoboli's lab from those same samples around the periodontal defects. And what they showed was there was a direct response with elevation of vascular endothelial cell growth factor, or VEGF, in the PDGF treated sites. So from an indirect point of view, the PDGF stimulates VEGF to be upregulated, which is going to cause new blood vessels to be grown within that site. if we think about Kaplan's #1 rule of osteogenic bone healing, it's that we need an adequate blood supply.
Exactly.
The second side is the PDGF is going to draw the bone healing cells into that area, expand their population, expand the new tissue production, and that effect's going to be potent for a period of time of 8 to 10 weeks. So it's sort of that combination that, in a nutshell, sort of really explains the best I can biologically what's happening without getting into a level where you would be talking about cell signaling. I'll leave that to Will's group
Yeah.
and some other more basic science researchers to try to explain. But from a clinical perspective, at least for myself, that sort of frames it for myself. And sometimes seeing what you think is not really possible sort of opens your eyes when you come back to these more everyday types of defects. And this is a vertical bone augmentation study that was published in 2006 by Massimo Simeone in co-workers, including David Kim, Isabella Rocchietta, my dad, and Joe Fiorellini. And this is really a landmark study in showing us what the potential is with PDGF. And at that time, if you told someone that you were going to take this bovine bone block, put 2 implants in it, attach it to a ridge where you've taken all the bone away and allowed it to heal with chronic healing, and that this, by soaking this in PDGF, it would stimulate this to all be bone and integrate the implants, they would tell you there's no way this could happen. But at 4 months of healing, on the left side, you see a GBR approach with just the block and a membrane, and you see residual graft particles, you see soft tissue ingrowth around the graft particles, almost no new bone formation. On the other hand, again, we've been told the bovine particles will remain forever, but at 4 months, you already have resorption replacement along the whole left side of this implant. You have dense new bone formation that's even come up over the top of the implant. So, this really opens your eyes, especially when you understand that this utilized the periosteal healing effect. There was no membrane on this case. The cases with membranes had less bone formation because it sort of blocked that cellular and vascular supply of being induced from the periosteum.
All right. So, Marc, if I may, you are explaining this very well and very clear. And even if I can follow, then you know that you're doing a great job. And I see a great response in the chat as well. You showed us some very difficult cases of compromised sites indeed, and you showed some amazing results. You've explained very well the potential and the amazing potency biologically. And the question that starts to pop up is, okay, so what are the drawbacks? Why would you not use this?
There's really not a lot of drawbacks. You have some added cost. So in the United States, I think I haven't looked recently. I think a single dose sells for a little under $300. So when you look at the overall cost of an aesthetic implant, I don't think it's a big impact on that overall cost. But you could say cost might be a factor. There's really not negative impacts. There's not a negative effect on the wound healing. There's not an intensive swelling response as there could be with some other biologics. And that's why
other side effects somewhere else or locally?
That's why I tend to use this on a daily basis, whether I'm doing, even with other large connective tissue graft procedures, I'll soak the connective tissue graft in it, put a couple drops in the donor site as well as the surgical site, and deliver it through the graft. It's something that I'm using relatively on a daily basis.
Wow, impressive.
There was also a question that you mentioned to me when we were just before we turned on the start, where you're talking about again the PRF, the LPRF,
yes.
And I think that for those that have less experience, what I would question is to go back to what we're just sort of looking at and turn this on again. And my question is, can you show me an example of this type of intensive bone healing with the PRF? Do we have the same type of documentation? And I would challenge you that it's going to be hard to find. And, there's a real potency to the way this works. And that's, I think an important issue. I think as far as the clinical experience, it would be maybe helpful to go back and look at the video content.
Yeah, please. Yeah, the
And
second part of the case.
let's look at how that case healed. See if I can find it here.
In the meantime, while you look that up, let me invite all our viewers who may have joined later or have just been sitting there and thinking, whoa, 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 this is EAO's Just Ask. We have at least about 20 minutes to go. Well, we have maximum 20 minutes to go, but this is also the time to send in your questions live in our live chat. On the right side of your screen here on YouTube, we are live. I'm keeping my eye on that. So if you have a question about anything you've seen, you've heard, or maybe thought while we were discussing this technique, please submit it and I will relay your question to Marc while we are still live. Marc, go ahead.
So here's the healing from the video of the extraction that we saw. And you can look at this at one of two ways. You can look at it and say, well, I still see that there's a dip to the ridge there. This didn't work. Or you could look at it and see that even this, there's a small indentation at the top of the socket, but it really looks like you got maximal preservation here. I'm not sure if I could have preserved a lot more with another minimally invasive technique. And what would the risks have been versus the benefits? If I'd opened a flap at that time, would I have more buccal contour? Would I have lost the papilla? We saw on the pre-op CT scan that the bone height was about 3 millimeters below the soft tissue level. So we expected to have a little bit of a dip there. And that was sort of why I preferred, rather than doing the immediate implant here, to do this in a staged approach. And let me just get out of this. And here it is at the day of reentry. And I can skip through this video a little bit. I want to look at the flap elevation just to demonstrate how thin the soft tissues are there, which again, you can see here at the vertical incision even, really extremely thin soft tissues, which is part of my hesitation for doing an immediate implant in this area and wanting to have more control or optimal control. And I'm going to combine now going back and doing my implant placement with doing a soft tissue graft. And we can try to. Sometimes the bone is grown right into the soft tissue layer. So I'll use sharp dissection to separate the tissue from the bone. And let this just run for a second. And here we can see with the flap elevated, this is about 5 months post-op, I believe. And from that point, I'm going to use a surgical guide to do my first drilling. And you can see, and then once I've done the first drilling, I'm going to switch and do the implant by hand. I think we have pretty nice bone preservation. Here's the implant going in place, and then we're going to do a soft tissue graft to augment the soft tissue. And so I'm going to harvest a subepithelial connective tissue graft from the palate, and I prefer to harvest it in a subepithelial fashion. Basically, it's a technique John Bruno published, I guess, 25, 26 years ago in PRD, as well as in chapter of textbook. And I'll just go to the palate. And here we'll make it 2 parallel incisions, and without any external verticals, just with the internal vertical, harvest a nice graft that we can use to augment those soft tissues. I'm going to suture that graft to the buccal flap in this case, very simple. I'll remove the epithelial collar before I do that. This is going to be closed with a continuous suture with a 6-0 polypropylene suture. There's just removing the epithelium from the graft. And here's the graft being sutured to the buccal flap. And I don't want to take too much time away here. We put a little double pedicle suture there where there's really thin, almost a fenestration. And once that's sutured, we'll just run some sutures to close this up nicely. And this should give us a very nice soft tissue foundation, as well as now having the implant in place. And pause that, switch back to the PowerPoint. And here it is at the end of the surgery. And here's the way that's healed. We've used I think a 2mm healing cap to help support the soft tissues. Here it is the day of uncovering and putting a taller healing cap on. And here he is with his implant crown. And I think we have a very inconspicuous result with strong, healthy bone and nice aesthetic soft tissue contours, but it's not a extremely sophisticated approach to get there. It's more decision-making of what we're going to do biologically. And, you know, in the same technique, as we'll see in a couple of case examples, can be used even when we have very, very advanced bone loss. This case, we're trying to intercept and have control of the hard and soft tissues with a minimally invasive approach. And I don't know if you want to hit any questions before we shift to those other cases.
No, at the moment we're still pretty good. One question I have myself is, obviously this is an amazing result, a very complicated case, and you say I use the stage approach. Does this just as well work in an immediate approach? You can do it just.
It would. It would. I just felt in that case that I'd have less liability if there was any soft tissue complication by handling this in a staged approach. I felt that, you know, I probably was 99+% that I was going to be able to get that type of result doing this in a staged fashion, and trying to do this in a single procedure was going to add a lot more variables, especially how thin his soft tissue was. He had the buccal plate starting 3mm higher. His overall bone wasn't that wide. We had a fairly good size of the tooth compared to the remaining bone. So there was a lot of factors that led us to say, you know what, we should be a little more conservative here to optimize the treatment.
Clear. Well, in that case, please show us some more examples, because I think by now we really get it. We see the power, and we love to see some more use cases and applications.
Yep. So this is in the beginning of 2006. So sort of when I was first, you know,
when you say this, I'm assuming that you think we see your slides, but we don't yet.
Well, so I always think you see my slides.
Yeah, but that's I'm here to help you. There you go. Yeah, there you go.
I need to turn it off to get organized. And so you can imagine that the tooth's almost being held in by the splint. I mean, there's just not a lot of bone left to hold this tooth. It's you can probe up the buccal plate where it's been draining from that periapical abscess. The abscess is more like the size of a small marble than the edge of the root. And this again was treated with a flapless approach. And here it is the day of the extraction. So it's very similar to what we just saw, except for the fact that I used a suture over the top of the ridge, a single chroma cut suture. And it was shortly after this where in 2006, where I said, you know what if we try this with a glue to reduce the compromise if that suture gets loose and creates some movement. The other thing to note here is I tend to prefer not to have that Frenum pull in the area when we do the aesthetic implant. So when I'm going in to do my soft tissue graft and we're going to thicken the soft tissue volume, I want to be sure I can get nice passive closure over the soft tissue graft. If I leave that Frenum in place, it's going to be pulling apically. It also may cause micro movement to the tissues around my implant and cause peri-implant inflammation later. So between the extraction and when the implant's done, maybe after 2.5, 3 months of healing, I'll come in and do a frenectomy. And then on a case like this, I'll typically, when it comes time to doing the implant, make a vertical incision off the lateral, come around the lateral, across the ridge to the other central, and do a single vertical incision, one tooth away to access doing the implant, combine that with my connective tissue graft, as we saw in the video, and we're able to get this type of result. This is the 8-year post-op photo there. I actually have to add it in. She came back for a follow-up recently, which is now, I guess, maybe close to 12, 13 years follow-up. But it's taken what could be a fairly complicated case, avoiding an intensive large GVR style procedure, and being able to get to a predictable endpoint. If we go back, if we look at something with even more bone loss, I think a lot of people would look at this example and say, well, I can't gain anything grafting this at the time of extraction. I'm just going to extract this and deal with it later. But then you're going to have a huge defect. It's going to be a big intensive GBR procedure. Whereas even with the recession and the frenum pulling, I'm still going to graft this at the time of extraction. And I got enough bone to be able to come back and place my implant in place. Here's where it was the day of the diagnosis, 100% bone loss. Here it is 4 months later with the implant and a year later with the implant crown in place. And if we look at the CT scan before the flapless procedure, and here it is the bone after the flapless procedure, just like the same technique we saw, but here we have more bone loss. Even with the recession in the frenum there, we're still able to establish all this bone regeneration. It took a couple of procedures to get the soft tissue straight. We did a frenectomy. We did a soft tissue graft at the time of the second stage, and then we did, at the time of implant placement, and a little more soft tissue grafting at the time of second stage. We had a chance when other implant was being done posteriorly to see a 2-year post-op here. And here we can see clinically, and here we can see the bone in the CT scan. All that bone was regenerated through this technique. If we go back to, I'm trying to get back to the first example. Let me just see where that is. It's coming up eventually.
Yeah, look it up, Mark. And well, let me remind our audience again, we have a few minutes left. And well, I see you're all staying. So, Mark, they're literally listening relentlessly to you. But let me also invite you all, if you're still with us and you have a question, now is the time. We have about 9 minutes left maximum to answer all your questions. So make sure you do a quick reflection, see if you know enough to get started. I have a question about that in a second, Mark.
Yeah.
But
let's look at these last couple of case examples. And here, this patient was told he would need to replace the upper left sentinel incisor as well as the lower left molar with implants, but no one really wanted to touch it. They didn't want anything to do with it. They were concerned about the aesthetics. And I apologize. I don't think I have I'm not sure I have the post-op final result in here right now, but I think just seeing the bone regeneration is pretty impressive. Here on the left side is the central site, flapless grafting going from where we were with the tooth in place to all this bone available for implant placement. And in the mandible, from where we were with 98% bone loss to regenerating this with a flapless approach. Here's the maxilla at the time of implant placement. And here's the mandible at the time of implant placement. So, a case that could be very complex was really simplified. Same thing here, staged approach for a lower incisor. You'd say, well, I'm sure you'll have to lose the central, but we didn't. We regenerated all that bone with flapless grafting. And this brings us back to that first case that we saw, which was the last example I think that we'll show tonight. And we did this the same way. Look at all the lack of support, 100% buccal plate loss. We packed our allograft growth factor matrix, collagen membrane just on the surface, wet that, add the periacral. We used an Essex appliance in the short term. And here at the 2-week healing, we can see the stability of the area. We already get the idea this is going to heal well. And this is what the bone looks like at 5 months. And we'll be able to do a pretty simple procedure of guided surgery, implant placement, a small connective tissue graft, and we'll let that heal for a few months. And then we're able to come in and, get a really nice result for this patient. So, let me just flip this for a second.
Well, in the meantime, Mark, if I may, we talk a lot about innovative stuff on this EAO channel, and we also talk a lot about learning curves. In this case, you've been doing this for 15 years, and thousands and thousands of cases. You say it's my go-to technique on an everyday basis. How difficult is it to get started with this technique in your protocol? Is there a learning curve?
I don't think there's a lot of learning curve except for having the confidence.
Exactly.
And I think there's so much research out there that if you look at the different preclinical and clinical data on PDGF for bone regeneration in potential implant sites, there's really a pretty wide volume of literature today, given that this has been approved in the States since December 2005. And I think it's more it's about the confidence. I think with any technique, you can't do one case and expect to understand what's going to happen biologically. I think you have to choose how many cases you want to do, whether it's 5 or 12 or 20, and look at that healing over the first 6 months, the first 12 months, and see how those cases turn out. But you need to do enough to get a feel for it to really understand it. But I think a lot of it's just about confidence. I mean, I've had friends of mine who spent time in my office extensively. So they spent a few days with me clinically. They've seen this done, and they'll either see these case examples in a lecture or more severe, say a molar with a huge blowout bone loss, but the soft tissue is a good height, and they'd or send me an X-ray. How would you handle that? I tell them I do it flapless, and they're like, "Really?" I'm like, "Well, didn't you see me show you this before?" And it's sort of hard to get past, you know, when you're in a paradigm of doing something a certain way, it's hard to sort of jump out of that and trust doing something differently, you know, can work. But I think we have a lot of evidence here to support the discussion. So it shouldn't be, you know, too far off.
Regarding discussion, Mark, we might have to take an extra 5, and I'm fully aware it's your afternoon, so you might have to go back to the clinic as well. But all of a sudden, now our viewers wake up and send in a lot of questions. So see how many of you we can still take in the last few minutes. We have George Zorojanidis saying, what are your instructions to the patient concerning the oral hygiene for the first days or weeks after the socket graft? Any specifics there?
Yep. 1 second.
You're checking in with your schedule at Great Public.
So oral hygiene wise, you don't want to disturb the membrane while it's in place. So I don't want them brushing over that socket and over the tooth or two next to it. I tend not to use a lot of chlorhexidine in my practice. I find that it probably isn't necessary for a single tooth procedure like this. Patients don't tend to like the stain on their teeth. They don't tend to like the altered taste. As it sticks to the teeth, they have antibacterial properties that sort of builds a tartar or calculus, which can become a nuisance. So I would just say, you know, gentle brushing away from that surgical site, and if you can, in the areas of a mouth or the opposite arch, doing flossing and your regular techniques. If you want to use a conventional mouth rinse, great, but I don't tend to use chlorhexidine for this type of single tooth case. I don't think it's necessary.
Very clear. Let's see if we can take a few more. Someone by EN, just the initials. Does this mean that we should do a bone grafting after a tooth extraction instead of placing collagen when an implant will be placed?
I think for sure. You know, in my mind, you know, and I think when you get into, you could have a whole nother discussion in, say, a mandibular molar area. And what I would look at is you can get great bone healing just letting the body heal natively. But what if your height of where that implant is going to be is 2.5 millimeters lower because you lost some of the height by the way the buccal bone had a little bone loss, or you had recession, you had a dehiscence that was down here, so it healed like this. Now that implant is lower, those contours become more difficult, food impaction becomes more difficult, potential for caries on the adjacent teeth. And so I think there's always a little bit of a domino effect with that. Also, I see a lot of patients who have an extraction and they come to see me afterwards, and it's not that they're missing 1 or 2 millimeters of bone, because also the techniques used for extraction for people that aren't thinking about implants might be damaging to the bone. I think a whole nother topic would be a great topic to have someone on this lecturing about would be atraumatic extraction, especially in molar teeth, because managing this without damaging the buccal plate is critical. And becoming very skilled at that is important to implant treatment also. So we see a lot of patients who didn't have grafting, but there was damage to the bone, and then things are really resorbed. You're talking 5 millimeters vertical, 5 millimeters horizontal, and those become serious defects to repair.
Yeah. Wow. Okay, so this is the EAO Just Ask pressure cooker. Let's see if I can fire a few more in the last few minutes. Per Ottestad, joining us from Norway, sending in questions before. He's asking, yes or no question, more or less, any experience with grinded / particular autologous dentin in augmenting extraction sockets?
A lot of scientific experience with it, no clinical experience or preclinical work myself. It's works as an adequate bone graft. There's some case examples of some histology with some mini implants even back into the bone around it. I don't know if there's a big drawback necessarily to it. I'm not sure what the necessity or need of it is and why it would be used, given that, for example, allograft is so readily available. So I don't see a clinical need for it in my practice, but from a conceptual biologic point of view, I don't see an issue with it.
There's potential. All right. One more. Gianni Salvini is writing, what about the risks of infection? And these all came in within 2 minutes in the last 5 minutes, Marc. What about the risk of infection of the graft materials?
Well, the graft material themselves isn't going to cause infection. If you're using a freeze-dried bone allograft or you're using a bovine graft material, these products don't bring any infective processes themselves. I think the key is cleaning out the infection from the socket. So a lot of these sites where I'm treating have had extensive infection, extensive granulation tissue, and we want to remove 100% of that inflamed, infected tissue and all the bacteria that go with them. I think if we're working in the mandibular posterior, we have to be especially conscious of our cone beam CT scan imagery and our location in relation to the alveolar nerve or the metal foramen. We don't want to cause any neurosensory damage. And if we're working in the maxilla, we need to know where we are in relation to the nasal floor or the sinus, always being aware of our anatomy. But we want to make sure we've completely debrided and degranulated these areas. I'm going to cover most of these patients with a pre-surgical antibiotic. I'll usually carry the antibiotic for 5 to 7 days. Non-allergic patients, amoxicillin.
Very clear. Well, Marc, I'm looking at the clock. I'm aware of your schedule for the rest of the day. I see still some questions coming in. So let me invite those viewers to also look you up on social media. You shared a slide with your social channels. You're on Instagram, both personally and with the office, Nevins Dental Center and Dr. Marc Nevins on Instagram. We see you're on Facebook as Marc Nevins and your email is on screen right now as well. And obviously, as soon in a few minutes as we stop this live broadcast, this video will remain available on the EAO channel. If you have not yet subscribed to the YouTube channel, hit the subscribe button right now, because you can then rewind this video, look at it again. You can share it with all your friends and colleagues, and you can also post your questions, remaining questions that we didn't get to, in the comments of that video. And Marc, hopefully you find the time at some point to maybe come back to this video and answer off some questions.
Yeah, I'd be happy
in the
to,
comments as well.
Thank you so much for being so kind in hosting. Appreciate it.
Yes, let me stop sharing your screen or ask you share your screen so we are nicely side by side when we sign off. On behalf of EAO and all of our viewers tonight, let me thank you very much, Dr. Marc Nevins, for joining us live during your busy days and making the time to prepare for this. I think it was very clear. I already saw some comments in the chat of people thanking and applauding you. So congratulations, well done on this EAO Just Ask. And for those viewers still with us, I already mentioned this video will remain available on the EAO channel. Please share it with anyone who you might think this is useful for. And mark your calendar for February 1st. That is the first Monday of the next month when we have another episode of this EAO Just Ask. That day I will be joined by Stefano Grassis. We will talk about implant prosthodontics, understanding the implant abutment platform configurations. Very interesting topic again. And again, we will answer as many of the questions you have. So with that, if you cannot get enough, keep watching, check out all the other EAOs Just Asked, and otherwise I look forward to see you back next month at another EAO Just Ask Live.
Thank you.